Joining me today is my incredible client and friend, Deepa Rangar. Deepa is a 22-year practicing doctor for NHS Lothian and is 10 years in consultancy as a geriatrician. She is predominantly looking after active aging patients in chronic disease and acute illness.
Thanks, Amy. Yes, my name is Deepa Rangar and I have worked in NHS Lothian as a doctor for 22 years. I became a consultant in geriatric medicine just over 10 years ago, and I specialise in looking after older adults with chronic disease who present to the hospital with acute illness. My patients have varying presentations, but often arrive in hospital having reached a crisis point. So presentations often with acute illness such as pneumonia or heart failure, but often with falls, delirium. And what these patients all have in common is that they are frail and they have chronic disease. So those chronic diseases could be anything from osteoarthritis, osteoporosis, dementia, heart failure, and other age-related comorbidities. And these patients can be really complex to treat. I mentioned that sort of clinical syndrome of frailty, which I'm very familiar with now. And what that really is for individuals is loss of independence. And that's really, really important for individuals because they lose their sense of identity, they lose their ability to leave the house unaided. And if you couple that with cognitive decline, life becomes really hard for these individuals. So my sort of clinical background is looking after these patients. And what I see is, patients who are so frail that I often reflect that this is something that, I'd like to, on a population level, we should be looking at and we should be treating with public health messaging, etc. But on an individual level and for the people that are closest to me, I see that this is something that I don't want to happen to myself. I don't want to happen to my own parents and family. So when I think about what we can do for patients like this, it's about shifting how we look after ourselves and really focusing on those really important lifestyle pillars, which we can integrate into our lifestyles at a much earlier age. So not just at midlife, but even before that. And sort of utilising lifestyle medicine as an intervention tool to prevent age-related disease and cognitive decline and optimise health in that way.
So I think that the reason that we wanted to kind of do this interview is because I'm dealing with my clients at this level already, that cognitive decline, during that consultation stage where they're explaining, the higher levels of medication that they're already on in their kind of 40s and 50s, that their lack of mobility, how they're showing up and they don't feel strong, they're not able to maintain their lifestyle or, simple functional movements like carrying their shopping to the car, and you can really see that kind of decline like we're saying there. So I thought it was really important that we hold this discussion just so that we can see when I've decided to create a business that predominantly is focusing on corporate women in that sedentary lifestyle who have got, less movement patterns, who don't necessarily resistance train and strength train, and focusing on kind of that preventative intervention in my end before it gets to you. So what we were talking about there, what are you experiencing when they're already getting to you, we're already on those high levels of medication?
So as I say, I look after patients over 75, but I've had a lot of experience looking after all comers, all adults over the age of 18. And what I see is that, by the time you've crossed the threshold into hospital, most patients are already on lots and lots of medication. And that's reflective of Western medicine. Often, if you go to see your GP, there often isn't time to discuss what really the driver is for illness in that individual. You know, in a 7-minute consultation, getting to the root cause of the problem is really difficult, and would often take multiple consultations. And it's far easier to prescribe a medication, and often that is what people expect. You know, when they go and see their GP, that, you know, we can fix this with medication. But what that results in is people accumulating medication as they go through life, and never coming off the medication that they were initially prescribed, not really understanding why they're on medication. And what I see in hospital is patients who present with what we call polypharmacy. So if you're on 6 or more medications, that is defined as polypharmacy. And the reason that's really important is because all drugs have side effects. All often drugs interact with each other. So there's these drug-drug interactions. And a third of hospital admissions to the front door, so a third of presentations, to the front door are iatrogenic. And what that means is patients are presenting to hospital because of side effects from their medication. So in an ideal world, we would have a system in which we can, you know, continually review and re-review what medications people are taking. But unfortunately, the NHS just really isn't set up for that. So to my mind, the key is to prevent that initial prescribing in the first place. And if we were able to do that, we would, in order to do that, we would, there would be a focus on what the person or individual can do for themselves before we reach for the medication. And that's where we start talking about all of the sort of evidence base for lifestyle medicine, preventative medicine, moving away from reactive prescribing, which is very, very, it's just embedded in how we practice medicine in this country, unfortunately, and most of the Western world. And it's sort of shifting the accountability to the individual. So I've started to develop an interest in longevity medicine, and what that is an evidence-based approach to improving not only health span but lifespan as well, and reducing the risk of developing age-related disease and optimizing health. And we look at that through really important pillars that you experience with your corporate clients. So often they're in stress jobs, so there's a huge wealth of science and knowledge around stress physiology and how that can be managed, not only before we reach for medication, so by the individual, and how we can track things like cortisol, salivary cortisol over time, for example, and how we can prevent the cortisol sort of chronic elevation. So that's really important for the clients that you see. And then there's the importance of exercise. Obviously, this is your domain, but increasingly moving away from using exercise just as a lifestyle factor, and moving away from short-term goals such as weight loss or fitness, and actually using exercise as an intervention to reduce mortality. And that's really important for midlife, for the people that you see in the corporate world. And then there's a lot of physiology around the importance of sleep, and we see that in the mainstream. And then there is the nutritional aspects of our how we eat, what we eat, our gut microbiome, how that influences our brain health, which is really important, and muscles and recovery. So all of these are sort of the pillars of lifestyle medicine that I have described. But what I'd like to see is individuals taking accountability for their own health at a much earlier age and preventing that decline, and using support such as yourself to have that accountability, but also sharing knowledge. And what I would say is that there's a lot of misinformation on the internet, on social media platforms. There's lots of influencers who aren't necessarily aware of the evidence base for things such as intermittent fasting, which may be applicable to one cohort of patients but not to another. And that sort of thing. So I think trying to get really reliable sources of evidence is key for individuals. People want to know exactly what the evidence base is. And that should be something that is accessible to everybody in a format that people understand and can apply to their own lives. One example would be something like, so thinking about exercise, so we talk about VO2 max. So VO2 max is now considered a core clinical marker for longevity. And that should sit alongside good blood pressure control and cholesterol.
Yeah.
Okay, so we know with VO2 max, for example, that any increase in VO2 max is associated with up to a 50% risk reduction in mortality, in all-cause mortality. That's massive.
Yeah.
That's absolutely massive. So VO2 max, sorry, just to say as well, is how well it's a reflection of cardiorespiratory fitness. So it's how well our heart, our muscles, and our lungs use oxygen during exercise. But from a medical perspective, this is massive, and it's not widely known the importance of VO2 max and any nudge that you can make in VO2 max, because it's all-cause mortality, but there's been shown to be benefits in cognitive health, in bone health, and in cancers, in cancer reduction. So this is an intervention which is key. And the reason VO2 max is something that's applicable to people that you see and people in the corporate world who might be drawn to a statistic like that is that you can monitor it over time.
Exactly.
And you can engage your client, and
yeah.
you can engage your client that way. And that's really key.
Yeah. So I think the touch on the importance of, I see a lot of my clients who are already, in their kind of mid 40s, 50s, even, my eldest client is 72 years of age, but it's more about there is that high level of medication already being used. There's a less focus point on the importance of their ability to be able to stand freely and balance. I've got a lot of women in their kind of, because of that sedentary lifestyle in the corporate world, that kind of 45, 50, where they've already lost their balance. They, I'm doing balance testing whenever I'm doing their biomechanical assessment, and they really could fall over very easily. Predominantly because they don't move often. They've lost that muscle support in the hamstrings, the glutes, and they're very sedentary for longer periods of time, and not realizing that really impacts them, like you said, preventative from getting to where you've already seen these patients up to 75 years of age who have got that frailty and that decline in their ability to move. And at that stage, it's just got too late. We're in that already. I think we talked about, you'd mentioned, once they have already reached you, you're only keeping them kind of with medication, or, you're not able to kind of already focus on their health, because their health was 20 years or 15 years before.
So absolutely. So I think one of my biggest career reflections is, looking after a group of patients who are elderly, who I see time and time again. So if a patient were to fall, that I see, for example, if they fractured their neck or femur, so if they have a hip fracture, they have a 10% mortality within 30 days. That means that they, there's a 10% chance that they're not coming out alive.
And what I would say is, like, so when I am dealing with my clients, what I normally predominantly see is that ankle stability, hip stability, and knee, where they don't have the functionality of that hip hinge movement. So that is already, there's a higher risk factor of slips, trips, falls, and fractures, where as they age, they don't have the same support network as what they would have if they are not resistance training, if we're not looking at interventions of lack of prescribing and focusing on their nutrition. That we talked about the protein synthesis and how the correct microbiome in the gut health impacts their cognitive function and so
Everything.
on. So their ability to function and not fall over at home and have a longer periods of life. I think I had attended like an event in Edinburgh where I'd met a lady who was a pharmacist, and she said when she's getting the notes through from the patient and they need a specific set of medication, on the notes it's saying long lie. Which is basically, their discharge notes is identifying that this patient has fell over and has been in a position where they were unable to get up.
So it's one of the commonest presentations that I see. So a patient that has fallen and has lain overnight, for example, and you develop something called rhabdomyolysis, which is muscle breakdown, and that can cause acute kidney injury. And that's really significant and often associated with death in hospital. So it may be that patient isn't found until the carer arrives the next morning, for example. And often by that stage, they've already developed an aspiration pneumonia or other complications of their fall. A fall with a long lie is a really common presentation. So
Sorry, even with that situation, what would your advice be? Because, you see people that are already on higher volumes of medication. So when they are taking, for high blood pressure, high cholesterol, or they're in chronic pain, they're still falling over. The reactive prescribing is not helping them with health at that stage because we're already in that decline.
So the decline has happened and these are often pretty frail patients. But what we do as geriatricians is if we were to specifically talk about the medications that they're on, we would look at those medications and say, which ones are actually harming the patient now. For example, if you've prescribed a statin for a heart attack at the age of 50 and you're still on it at the age of 75, that statin may actually be causing it may be having an adverse effect on your muscle strength and balance. Okay, so that is often the statin is the first thing that goes when you see me, for example. So we do a lot of what we call deprescribing. So looking at statins, looking at anticholinergic medications, which often people are on for bladder instability or sleep medications to help people sleep. They are anticholinergic medications and they can affect your balance. They can affect your vestibular system. So how you and I would correct balance is no longer possible in these individuals because it's being exacerbated by these drugs. The other thing that I commonly see is something called postural hypotension. If I stand up, my cardiac reflexes allow cerebral blood flow to my brain. That means that I will not faint. However, if you're on 5 antihypertensives for blood pressure, you are unable to maintain your blood pressure on standing and you fall. So there's loads of side effects with medication that might exacerbate that fall and long lie. And then, of course, there's all the complications that come with the fall itself. The reason the fall is important is because once you've had a single fall, you are at much more elevated risk of having further falls. And with that comes loss of confidence, loss of independence, low mood, cognitive decline, and I see this downward spiral in a lot of patients that I look after. Medications is massive, but then you talked about physical activity. So if we look at government guidelines, the minimum recommended guidelines for physical activity are not enough to prevent those age-related.
I nearly want to say it's 30 minutes up to.
It's
times a week.
It really is very minimal, and that is things like walking, which is fine, which is good, and it may have an impact on cellular aging and VO2 max to some degree. But actually, as you know, this is about moving to midlife and starting that resistance training early, isn't it? Really trying to maintain the muscle mass that we have, because muscle mass is so key to, it has a massive impact on bone health. So many of my patients are osteoporotic.
Yeah. And I have a high volume of corporate women or in consultations where we're already, potentially grade 1 osteoporosis in that earlier stages. If we are perimenopausal, menopause, we talked about that kind of 3 to 5% decline of bone density issues even at those earlier stages.
It's massive.
Imagine if you're someone who is a corporate woman who's in a sedentary lifestyle, which is a high pressured environment with chronic stress physiology. You don't sleep well, you're skipping meals, maybe not having breakfast and going straight for that cortisone spike we talked about in terms of caffeine dependency. Like there is the reason for us having an intervention in the lifestyle piece rather than them getting to your stages of hospital and we are in those mass amounts of complications and it's just non-reversible at that point.
I think we probably don't take the risk of osteoporosis seriously enough. We have, everyone in Scotland has lack of vitamin D. Yeah. Everyone for midlife should take vitamin D supplementation in the UK. And then if you add in the risk factors such as smoking and alcohol, you have an exponential increase in your risk of osteoporotic fractures. And women don't know that.
And well, what I would say is predominantly if I speak to these corporate women and they might be experiencing menopausal symptoms already, and then they might have a high volume of alcohol throughout their week because they feel quite stressed or overwhelmed in that environment. They feel like that kind of takes the edge off that stress level, but not realizing the implications and impact in their overall health long term when we have that risk factor already with everything else we've just touched on.
Yeah, I mean, alcohol is huge, and I think in this the patients that I see of all ages who have drunk to excess have chronic disease. It's multi-system.
Yeah.
So it is alcoholic fatty liver disease is a huge problem in this country, alcohol related cirrhosis, and then type 2 diabetes, cancers that are implicated, that alcohol is implicated in. So that alcohol is used freely in this country and is obviously widely available. However, I think the public health messaging around alcohol really needs to change, and that needs to come from government policies around alcohol. But there is a lot of information out there already, and I think that part of this conversation today is thinking about how an individual can take accountability for their own health. Thankfully, rates of smoking are much, much lower than they have been in the past, and that's great. However, we're still seeing cancer rates increase. So why is that? Is it just related to chronic inflammation? What are the other risk factors? But alcohol is still very predominant in this country.
And I think when I spoke to you, when we came on to talk about where do you normally see the kind of earlier stages, what I think we talked on, it was from inflammation, like different areas of the body that became inflamed.
Absolutely every chronic disease that you can develop is related to chronic inflammation. The other drivers of chronic inflammation are sleep deprivation, and that's massive. And chronic stress.
Yeah.
So these are all endemic in our society, and they're all things that we have the power to fix ourselves with the right tools, with support from people like yourself, from arming ourselves with the correct knowledge, not looking at unreliable sources of knowledge.
So I think this is why I wanted to, because when I wanted to create my business predominantly focusing on these areas with my background and with clients like yourself that I work with, I thought it was really important that we have it directly from source. So we've got it from real life experiences that, you know, you're at the forefront of what you do and what you see every day. I feel like social media sometimes can have that 5% health, and the rest of it is you know, noise around different things, but there isn't a real true reflection of information where people can go to feel they get a better understanding of what actions they might be able to take. Like we say, taking responsibility for specific things that you can do yourself. So I think it's really important that we focus on the real information, and sometimes the things that can be fabricated for personal gain.
100%. And sort of related to that is the you know, we're very fortunate that we have, you know, that we live in an era where we can stay alive due to vaccinations and antibiotics and all the other amazing, you know, advances in modern medicine. But what I would say is that if you have a heart attack at the age of 50 and you have a stent put in, you know, 50 years ago you would have died.
Yeah.
So because of modern medicine, we are able to keep you alive.
Yeah.
And often when I meet patients who have had that crisis happen to them in midlife, it's often a trigger, you know, to say, hang on, these are the things that I need to change. I need to stop smoking. I need to start exercising. I need to, and sometimes you see that. But more often than not, I meet patients who have done that for 6 months and it's all become too difficult, and they go back to their ways. And that always surprises me. And I don't know if that's because I am a doctor, so, you know, health is, you know, at the forefront of my mind. But that's not to say that, you know, those people don't want to change. They just may not have the tools available to them to do that. So this is coming back to that sort of piece about having information widely accessible, but also having, you know, having local gyms that people can access that aren't expensive, being able to be outdoors in safe environments for women, for example, who want to exercise, want to go for a run in the evening, for example, you know, having safe spaces, but having accessibility. But as I say, you know, that trigger is, you know, often a catalyst for people. But something around behaviour is not, this behaviour is often not sustained. And why is that? Is that because of fear? That this is all too difficult, and these lifestyle changes are not possible in the environments that people are in. You know, there's a lot in this, you know, in the UK about, you know, people say it's more expensive to buy healthy food, for example.
Yeah.
It's much easier to go to the supermarket and buy ultra processed food, which is cheaper, okay, and it lasts longer, so there's a longer shelf life. And I can feed my family with that. That's where the government comes in. That's where we need to change. We need to be able to influence health policy. And we can do that. And we can do that, you know, from a medical perspective. But real life cases are really important as well. But I think coming back to the individual is having that accessibility of information, which is something that you'll be, you know, that you provide with your platform. And there needs to be more of that, along with, you know, I think in medicine now, we have moved away from a paternalistic model, which is where the doctor tells you what to do and the patient does it. So what we try very much to do in healthcare now is a shared decision-making approach, which means that we're talking on the same level, and that kind of didactic approach is taken away. But in order to do that, the individual needs to step up and do the things that we are asking them to do.
Yeah, and I think we talked about sometimes there is an expectation on a clinician or a doctor to have all of the answers. And that takes that level of responsibility away from the patient or the individual to try. And it's more times than enough the pressure on because I work with a few doctors, so they tell me there is that pressure of, if I didn't prescribe or I nearly want to try a different approach, the patient is nearly not happy, because they're so conditioned to understand, I've got a problem, I should just take a tablet, rather than us maybe working on applying more methods. Is there simple things that we can use to improve your everyday, and it doesn't have to be massive changes overnight, because again, a lot of people that I work with, there is that, what if I fail at this? What if I'm not good enough? There's that expectation, and that can go way beyond health and into childhood and other things, about the expectation of them being able to actually create change, because change management is so challenging. People don't understand, when you have done something for a prolonged period of time, it's really hard to make change in sustainable habits in a different direction. And again, like you said, taking into consideration, where they, the area that they may live in, the finances that they might have available to them to feed their family, like all of these things take into consideration when they try to apply change. But the expectation of the doctor, can you give me a script? And you said we've got 7 minutes. I think you mentioned there 7 minutes in a GP consultation around.
Yeah. A GP consultation in Scotland is typically 7 minutes. That's never enough to address the root cause of somebody's presentation. But it does come down to expectation of a medication, and I think that it reflects the society that we're in, and that we live in such a fast-paced world that actually a quick fix is what we want, because we just want to be able to get on with our day and do all the things that we need to do. But I think if people were aware of what these medications could potentially cause, they would be, and often people do, and they read I meet lots of patients who say, oh, actually I didn't take this because of X, Y, and Z. And that's fine. But I think that involves a conversation which you can't have in 7 minutes. When I prescribe a medication to a patient, I always counsel them about the side effects. And there are alternative medications that they can have if that medication doesn't work. But the first approach would always be, if possible, to avoid the pharmacology and to implement some other change. For an older adult, an example is what we call social prescribing, and I know that sounds really odd, but so many of the patients that I meet are isolated. A lot of their loved ones have died, their spouse has died, their children live in a different country. I see so much loneliness in my practice, and that can exacerbate the risk of the fall, or the risk of developing a pneumonia from being bedbound, or that that kind of thing. So that social prescribing is so important. Having a community, having people, having a network, a reliable network, and people around you. So these are the things that are so they're relatively easy to sort of intervene in. There would be a huge cost benefit to doing simple things. We would save the NHS a lot of money if we didn't prescribe as much medication as we did.
And I think that's why I wanted to develop my business and work on other ways that I can have preventative care measures in place for my specific client, building that community piece where when we are in a leadership role, or when we're in a leadership position and we've got a higher level of responsibility, it triggers, stress, sleepless nights, self-doubt. And I even remember, whenever I had to make decisions with my teams, I would be awake at night, and I would be like, okay, so did I make the right decision? Will that impact multiple factors? And that played a part in my health as well, in my decisions. But when I was looking at corporate women and how I can support them, the main thing that I wanted to do was to create a community. So a community of women who, when you are making these decisions in business, you have got a support network to touch on of other people who experience the same things as you. Because I think I shared recently, a carousel slide just on my page on Instagram about like 80% of happiness is built in social prescribing and social connection, where you can connect with other people that you can relate to, or you know, create activities with. And I think that was also a drive factor, because I remember making those decisions and I didn't have a support network because I was the leader. I didn't have someone I could touch on, which caused sleepless nights, increased stress, even in my own personal life. And that impacted my health. And that was the connect factor of why I wanted to do this.
No, I think that's so important. I think that women in leadership roles are more vulnerable to these things, because we are generally the more empathetic sex,
Yeah.
and we do care about the people that we look after. I'm not saying that men don't, but their approach is often different.
Yeah.
And the way that they manage stress is often different anyway. But women often take on quite a lot of the kind of those factors for the people that they're working in, often to the detriment of their own health. And so you know, we want to lead, we want to be good role models, we want to be good examples of what we do. I have multiple leadership roles in the job that I work in. And I, you know, for example, you know, the junior doctors will look to me for support, advice, pastoral support, all of those things. I need to be a good example to them. And what that looks like in the real world is that I show them that I'm human, and I show them that I can't do 10 things at once, and that's okay. That's an example of, you know, how I manage my stress.
But also, you have a fantastic coach, of course, which is me.
And that's you.
But also, I would say, like, you predominantly exercise 4 to 5 times a week.
Yeah.
You are mindful around the food choices that you use. You meditate and create a space for yourself so that you can function in those high pressure environments. If someone is turning to you for support, you are prioritizing your health and well-being first. So it's a lot easier for you to pour into teams, to pour into your leadership role in medicine, because you are prioritizing you. And that's what I constantly touch on with corporate women, because we put ourselves last. Everything is in guilt, rather than if I just walked more, or if I did try and go for a walk on my lunch break and create some space in nature, that I might actually feel less stressed. And that less stress will impact health, longevity, etc.
Absolutely. And, I think, you know, this is probably the part of this conversation where I have to thank you, because because you have been amazing support. And, you know, I'm on my own fitness journey, and I'm, you know, so many of the things that you have taught me, I've, you know, because I will very much look at things from a medical perspective, but you have given me all of those extra tools to be able to implement change, which, as you say, is really hard. And it is hard if you're a working woman. You might be a mother,
Exactly.
but you might be in a leadership role at work, and you have lots and lots of responsibilities. But actually being able to use the community, the network that you've developed, the individual one-on-one support, the knowledge and the expertise and the experience that you've had in being able to transform people's lives is really, it's something to be so proud of.
Thanks,
and that's
Deepa.
been fantastic.
That means a lot. Thank you so much. I think being able to collaborate with other women, bringing women together so that they can have that support network that is a trusted environment. Because sometimes, obviously, when we are front facing, you don't as much as we say we can't, we don't have that level of vulnerability. Because we're professional. We do hold that standard for ourselves, and it can be quite challenging that, you know, we're having a really bad day, or we have to regulate our own emotions before we go to try and deal with a sick patient, or me dealing with it with a client or someone in the corporate role. It's hard for us as well, and I think it's really, really important to recognize that, and that's why I wanted to build a community.
I think that, and you know, it's probably good time in the conversation to talk about menopause, you know, which is what so many of your clients will be experiencing in midlife. And, you know, the really interesting thing about those menopausal changes is that, you know, I could show you a list of 100 symptoms that you could develop in the perimenopausal period, which can be up to 10 years of your life. And as women, we spend so long, you know, wasting energy wondering why we are behaving in a certain way or thinking a certain way or feeling a certain way. And often it is because of hormonal changes. And I think the moment you start to understand that and start to have that network where you can turn to a colleague and say, oh gosh, this is what's happening to me. Has that happened to you? And then you reach that commonality and you share that understanding of what your symptoms might be, which may be very, very different to the next person. Else, you know, that is huge. And you know, I don't think we can underestimate the impact that menopause has in the workplace for a woman, because we know it's associated with sleep deprivation. We know it's associated with low mood. We know it's associated with low libido, for example. You know, so many other factors, irritability, cognitive decline, that sort of brain fog that you know that we hear about. You know, I've experienced all of those things, and it's hard and it's really, really, really difficult. But just having somebody to bounce really those conversations off is so it's huge, and it's not something that my parents' generation talked about. So my mum had the most awful menopause, but she barely spoke about it. When she did speak about it, it was a bit taboo and it wasn't, you know, mainstream. Whereas now I'm really pleased to see that we talk about it much more openly, and there are better treatments available, which is fantastic. And one of those treatments, as you know, is exercise.
Resistance training.
And that's, you know, and that is something that I've implemented myself, and that's been fabulous for me, and has worked for so many people, and I'm sure has worked for lots of your clients as well.
Yeah, definitely. Well, Deepa, thank you so much for coming on. It's been an interesting conversation. We've touched on so many different topics. And again, I thank you. And I'm so blessed to have you as a client.
And I've been blessed to have you, Amy. Thank you.
And thanks so much.